I'm going to go ahead and start with my talk, which is on M0-CRPC. And I'm not sure, how many more years we'll be able to give this talk, because it is sort of a shrinking component of our therapy due to all the confounders that we've been talking about today, including advanced imaging. But it's certainly an important part of our management, just like early biochemical recurrences. And so we're going to go ahead and cover it. And these are my disclosures. So we'll talk a little bit about the risk, patient selection, and what we deem as risk stratification, what is available through the guidelines for recommendations based on the 3 pivotal trials, and end with a little bit of contemporizing it in summary. So we all know about the burden of prostate cancer in the world, but in the United States, it remains, the #1 incident cancer. And of course, for African American or Black men, it's much higher incidence for them. It still remains, unfortunately, the #2 cancer killer. And I thought maybe a long time ago when we started this course that with these new medications and all the things that were happening, we would cure some of the cancers. But really, we haven't gotten to that point where we really cure metastatic disease yet, but we have improved significantly. Unfortunately, though, there's been an uptick based on the epidemiologic data, somewhere in the 4 to 5% increase in the discovery of advanced prostate cancer at presentation. And so, there are lots of reasons why that may be happening: access to care, controversies around PSA screening, et cetera. But I don't think that we're going to be able to put down our tools anytime soon. And I think more than ever, we're going to need to know how to manage men with high risk and advanced prostate cancer. So I'm delighted that we've had so many attendees today, and it seems like each year the interest just increases. So why focus on non-metastatic castration resistance? Well, as you can infer from a lot of the trials that we've shown, they almost all started with their indications in the castrate-resistant, really advanced, late-stage metastatic burden, and you got a slight signal, some efficacy. But as we've moved them back in the disease state, we've seen significant better improvements. And so the lower the tumor volume, and maybe you would say if it's invisible to imaging, that would be even our best opportunity. It's only in the circulation, it's too small, less than 3 millimeters, for example, to show up on imaging. But we know that when we do move these drugs back into earlier disease state, we get a better response. And the development of metastatic castration resistance is really equivalent currently to a lethal sentence, so we'd really like to prevent that if possible. So there is a window of opportunity when these patients have low disease burden, and we may be able to make an impact on them that could be lasting. Now, thankfully, as a speaker in the early afternoon, these medications, the second generation novel AR targeted therapies have already been introduced to you, so that's not really new, and their mechanisms of action, Dr. Gerard kind of showed, but it's not just like your old Casodex, for example. And these are thought to be at least 10 to maybe higher fold magnitude of impact on the cancer as compared to what we had with bicalutamide. So these are potent, and added to conventional castration, they really have made a difference. When we first started out doing studies looking at people who were looking at bone health, for example, and denosumab, and wondering about how that might impact, we started recording things, and one of the things that was noticed is that the PSA doubling time was a powerful predictor of that bad event, the development of metastatic disease. So they'd come in to get screened for the study, they wouldn't have metastatic disease, they couldn't get in the trial, but they would follow them along, and then they would find, lo and behold, if your doubling time was 10 months, 9 months, 8 months, you would ultimately develop metastatic disease, and usually a pretty high preponderance of that in the first year or two. So the PSA doubling time, even though the number was absolutely low, was a good predictor, and it really stands still today that the risk of developing metastatic disease in this patient population is highly predictable based on that. You've already seen from Dr. Stratton's talk some of the patient information when we look at advanced imaging, PET imaging, PSMA PET, and this was a retrospective study that was published not too long ago, but it really looked at the what if, these patients that were in our M0 category had undergone PET scans, and it's not surprising that almost all of them would have had something demonstrable, 196 out of 200 in this particular study. Now, some of the studies did include patients with pelvic lymph nodes, so it's not surprising that some of that occurrence would be there, but more than half of them would develop metastatic disease and would be visualized on their PSMA PET had those studies been conducted today. So I think that we really need to know that, one, the good news is that this combination doublet therapies that have been effective in M0 are going to be effective in the M1A particularly, as well as in the pelvic nodal patients, as well as the fact that we need to do more studies to move the needle now that we know that this doublet combination is effective, and how do we combat the known metastatic sites that we can now see. And Dr. Stratton mentioned Will Rogers. Will Rogers from Oklahoma. And during the Dust Bowl, we actually had a little mini Dust Bowl the other day where a lot of dust and smoke from the west from fires and things came into Oklahoma, Kansas area. But during the time when there was a migration out of Oklahoma to California due to that phenomenon, he commented that that by the Okies, which was a derogatory term at the time, moving to California, that they had raised the IQ of both states. And so that's what Dr. Stratton was alluding to when we have this new imaging. And so in medicine, as many of you know, like when they first developed CT scans for lung cancer, people started seeing very small volume metastatic disease. So then that improved the outcomes of patients with metastatic lung cancer just because they were more early detected. And then the truly negative patients were also enriched with a better outcome because they were truly negative. So you can raise the outcomes and survival rates just by recategorization, and that's what this is alluding to. And again, that when Dr. Jared showed that high preponderance of M1A, I think that's kind of a really exciting new area for us. But when you have nodal only, usually a very responsive situation for some of our therapies, we need to figure out how best to consolidate additional therapy to get more, get patients further down the road and maybe add cure to the discussion. So we've already talked when you have patients with a rising PSA, and these are patients with a castrate level testosterone, but their PSA is going up. We use a combination of imaging. Now it's recommended to use PSA imaging, and that is in somewhere in the 6 to 12 month interval, as well as periodic, and that could be 3 to 6 month PSA check. So that is what is recommended in the guidelines for monitoring these patients before you institute treatment. In 2018, everything was really a mess with this disease state because these patients were out there, but nobody had any scientific way to manage them, so it was dealer's choice. And the FDA realized that we had a problem, and they had a committee meet, and they decided that they would move forward with a metastasis-free survival endpoint for trials in this space. Now it doesn't seem like that would be a big deal, but it was a big deal because, previously things got approval only based on a survival outcome. And so there were 3 AR antagonists that I mentioned earlier, and these all 3, through independent trials, were compared to placebo in men with continued castration resistance in the M0 space. So these are sort of based on their alphabetical. There's no priority here, but apalutamide was the first trial, and that was the Spartan trial. And it was a 2-to-1 randomization. To be in it, you had to be qualified based on non-metastatic CRPC. That was conventional imaging. They enriched the population because they knew the doubling time would help to predict the bad event of development of metastatic disease or death. And so they did allow for patients with small lymph nodes on their conventional imaging to be in the trial. And again, the primary endpoint was that new endpoint of metastasis-free survival. This is just kind of a table of the patient types that they enrolled, but notice that the doubling time was around 4 months for these patients. So clearly it was an enriched population to show the endpoint that they wanted if it were to be out there. And this was the results of that Kaplan-Meier curve with a metastatic metastasis-free survival, highly significant, hazard ratio of 0.28. And you can see that adding apalutamide to the mix was successful. I'll go through these AE slides. They're all in your packets, but we know that these medications added to ADT or conventional testosterone-lowering agents have some side effects, and we're all familiar with those for managing our patients, things like fatigue, hot flashes, some hypertension. Unique to apalutamide at this time was the rash, as well as the discovery of some lowering of the thyroid medication, so we are recommended to follow their thyroid functions, get baselines, as well as follow them when they're being treated with this. But by and large, in this trial was very well tolerated, and the discontinuation due to the side effects was very similar just to the placebo. So this is the difference. So it was statistically significant, but it was meaningful clinically to the patients because a little over 2 years of additional preventing or staving off of the development of metastatic disease in these patients. Remember, these are usually, other than the ADT side effect, asymptomatic patients. So it's important that they had quality of life preserved and maintained. And so that was some of the companion information that came from this trial and the others that I'll show you, is that it was maintained, and we really weren't making a big negative impact while we were improving the metastasis-free survival. And then an update of this trial showed that that did translate into overall survival. And so that was really good news, because I think when we used to present this information, especially if there were many medical oncologists in the audience, they didn't really care much about the data because it didn't show the overall survival, which they all think is the end-all be-all. And we agree that's an important endpoint. So I was happy to see that there was overall survival, and now they even can talk about it and be proud of it. Aramis was another trial, so very similar design. This used darolutamide as the novel ADT. You can see it was, again, a 2-to-1 randomization with patients with doubling times of less than 10 months with a primary endpoint of metastasis-free survival. The median PSA in these patients was a little higher than maybe what you would start today. It was around 9. But again, the doubling times were in that 4.5, less than 6 months for sure on average for those patients. And again, you could almost superimpose these Kaplan-Meier curves for the metastasis-free survival from the different trials. The hazard ratio in this one was 0.41. So side effect profiles are shown here. Again, if you look at like discontinuation due to the medications, it is similar to placebo, so well tolerated, and the usual side effects that you'd expect with adding on the additional novel hormonal therapy, but they did, have a pretty favorable, very little cognitive disorders and memory impairment and stuff. And it was mentioned earlier about the blood-brain barrier, and that this particular agent doesn't seem to have that crossover, so maybe a little less cognitive impairment. And again, preserved quality of life in these patients, particularly with respect to their bowel and urinary symptoms. So then this was almost 2 years of metastasis-free survival benefit with the addition of this agent, and then again with longer follow-up and subsequent publication, an overall survival benefit, and again, very meaningful to the patients. Lots of these studies had secondary endpoints like avoidance of chemotherapy, time to skeletal-related events, et cetera, and those all were important and positive in these trials. The PROSPER trial was the first trial, but alphabetically enzalutamide is the third trial, and that also used the same schema, and again enriched for patients with rapid doubling times. They waited till their PSA was above 2 to be in the study, but a rapid doubling time of less than 10 months. And again, placed the patients on active agent versus placebo, and the patients did, by and large, more than two-thirds of them had PSA doubling times that were in the less than 6 months. These were the results, again, highly significant metastasis-free survival, so they met their primary endpoint, And by the way, these drugs got their approval based on that metastasis-free survival. The AE events for enzalutamide are listed on this table, and again, similar to what you would expect with the fatigue, hot flashes, some hypertension. I think Dr. Jared had showed this a little bit earlier too. There is an apprehension about seizures in this patient group, so avoidance of that is usually recommended. The patients, again, had almost 2 years of meaningful metastasis-free survival. This was their quality of life table that, again, showed that patients had stable or improved quality of life while on these agents, so that was important. And then, like the other trials that I've shown you, there was an overall survival advantage that was about a year over the patients that were treated with placebo. So all good news. Everybody always asks, like, which one would you use? How do you do that? And there's no right answer there. They have not been compared head-to-head, so that you'll see that in the guidelines that we don't have to pick a favorite. There has been some real world, like looking at patients that are in this category and their pharmaceutical inquiries, and this was a study that was presented several different formats, but the DEER study looking at real world comparing in the non-metastatic CRPC, and you can just deduce from this that the darolutamide in this group of patients had less drug discontinuation. So inferences that may be less side effects, maybe better tolerated, and that could translate into an outcome later. But it's certainly not a comparative efficacy type study. It's more of a real world kind of look into the EMR and prescribing patterns in these patients. It's also been shown, we saw some meta-analysis earlier. This was a meta-analysis of the 3 trials combined, and again, overall survival was significantly improved by adding this novel hormonal agent, all 3 of these agents over ADT alone, and so it really is a standard for this patient population. So back to the guidelines, it's recommended that patients be offered either apalutamide, darolutamide, or enzalutamide with continued ADT in that high-risk category, and that is those rapid doubling times, and they defined it as less than 10 months. Clinicians may and should probably recommend observation for those patients with slow doubling times, but monitor them closely as they are at risk for development of disease. And again, these recommendations and these studies were obtained prior to PSMA PET scans, so that adds an extra wrinkle here. And then there's no role currently outside of a clinical trial for immunotherapy or chemotherapy in the non-metastatic CRPC patients. So in summary, patient selection is an important component. FDA approvals were based on metastasis-free survival, but we now know that there also is overall survival, and that's important when we're counseling our patients. It certainly is acceptable to observe some of these men, especially with slow doubling times, just like Dr. Borjan kind of talked about in the patients who failed primary treatment with early BCR. There are subsets of patients that are appropriate just to be monitored, and quality of life is an important issue, and added to the ADT in these patients was maintained or improved in all settings. So the 3 studies that I've mentioned to you are listed there. They were landmark, they were important. This was a data-free zone when we very first started talking about this, and then quickly filled with 3 important studies that gave us some information. And then time moves on, and with the development of the PET scans and enhanced imaging, we're now having to wrestle with how does this data apply to patients who fit the criteria, but now have some findings on their PET imaging. And we can talk about that maybe during some of our case presentations a little bit later. These were all approved, these agents, based on, they're not restricted by the doubling time. If you have non-metastatic CRPC, your patient doesn't have to have a calculation of the exact doubling time to be qualified for these drugs. They're approved by the FDA just for the disease state. But again, the decision is always going to be individualized with the patient, and you can use the risk factors to help drive your decision making.